Well, it's 12 o'clock. I could go ahead and get started and introduce you. And people are just hopping on right now. So I'm going to go ahead and introduce you if that's okay. Hi, I'm Cynthia Snedden. I am a member of the Education Advisory Board at the Cancer Center here. And it's one of my pleasures to be able to introduce speakers at our Lunch and Learn. We really appreciate everyone who is in attendance, and I'm going to go ahead and introduce Dr. Rita Lee. Dr. Lee is a professor in the Division of General Internal Medicine at the University of Colorado School of Medicine. She received her medical degree at the University of California, Los Angeles, and completed internal medicine residency training at the Cleveland Clinic Foundation. Dr. Lee has a passion for medical education, leadership development, and advocacy. Dr. Lee is the Director of Health Systems Science and Health Equity Education, the Chair of the Health and Society, and is leading a team focused on integrating health systems science education into the new curriculum. Dr. Lee also serves as Director of Health Equity Education and Training for the Anschutz Medical Campus. She is core faculty for the Association of Chiefs and Leaders of General Internal Medicine, ACLGIM. I had to look that up. So, which is a faculty leadership development program. She also serves on the Society of General Internal Medicine Council and serves on the National LGBTQIA+ Health Education Center Advisory Board. Her advocacy work has been primarily around lesbian, gay, bisexual, and transgender health equity. She is one of the founding members of the University of Colorado Health, UC Health Integrated Transgender Program, a multidisciplinary clinical program to provide gender-affirming care to individuals with gender incongruence. In addition to her clinical work, she has partnered with the local advocacy organizations to develop trainings and work towards systems change to improve LGBT health. Well, considering the many responsibilities and passions that Dr. Lee must manage, I'm really grateful that she's graciously agreed to be with us for this time today, and we look forward to hearing from you. Thank you, Dr. Lee.
Great, wonderful. Thank you so much for inviting me. I really appreciate it. And let me get my sharing screen going. We'll see if it works. Did this work? Perfect. Okay. So we have actually renamed ourselves in the 3 weeks since we were asked to do this session. So we are now called the Health Equity in Action Lab. And I'm accompanied today with my partner in crime, Christy Angerhofer, who will be helping me with the chat and chiming in whenever she sees fit. And so I have no financial disclosures. And really what we're hoping to do today is get a little bit of kind of some definitions under our belt so that we are all on the same page in terms of understanding the difference between equality versus equity in the work that we're doing. And we really want to describe some of the structural factors that impact health and well-being. And in this part, we're going to specifically think about how this applies to the Cancer Center and the work that you are doing. And then to identify behaviors and strategies to get us towards working towards health equity. Before we begin, I do want to set some community norms so that we all can lay a foundation for how we want to be interacting with each other. Okay, my goal is really to create a brave space where we can all be present and interact with each other. Ask what questions you need to ask so you can move your own growth forward, knowing that everybody comes with a different perspective and comes from a different place. Okay, so in terms of confidentiality, general concepts are like what is says here can stay here, so you can feel safe sharing maybe a personal story about what it's been like for you or some of your experiences. And then what is learned should really be shared broadly. Okay, we want those lessons to kind of diffuse out into the communities and the spheres of influence that we have. So we can begin to change our campus culture. Okay. And again, we want you to be present with an open mind as well as an open heart to understand that all of us bring different lived experiences to this conversation, and to create a learning community that will continue to grow even beyond the actual hour that we have together, right? So we want to lean into discomfort and recognizing that discomfort and personal growth are very different than it not being safe, and recognizing where those boundaries of safety might be for ourselves. Okay. And then engaging and listening for understanding, right? We're going to hear each other out if we have different perspectives, so we can understand each other's perspectives and not so we can actually formulate a response. Okay. And then trying to respect each other's different experiences in a way that's meaningful for ourselves. So when we think about equity and cancer, right, this is data from the National Cancer Institute on disparities that are related to cancer and cancer outcomes, right? We have to ask ourselves, why do these disparities exist? We know from our data, right, that Black individuals have higher death rates than other all racial ethnic groups for many, although not every single one of the cancer types that are out there, right? And despite having similar rates of breast cancer, Black or African American women are more likely than white women to die from the disease. We know that incidence rates around colorectal, lung, and cervical cancers are much higher in rural Appalachia than urban areas of the region. Okay, and we also know that education has an impact, right? Those who have more education are less likely to die prematurely from colorectal cancer than those with less education, regardless of race or ethnicity. Okay. We also know that Hispanic or Latino and Black American women have higher rates of cervical cancer than women of other racial and ethnic groups, right? With African American women having the highest rates of death from the disease. Right? We also know that there is a long history related to cervical cancer around the cells that were illegally and unethically stolen from Henrietta Lacks, and the saga that continues, and what does that legacy lead us today in terms of how we are viewed as a medical institution in certain communities. Okay. We also know Native Alaskans, Alaskan Natives have higher death rates from kidney cancer than any other group. Okay. They also have highest rates of liver and bile duct cancer, followed by Latinos and Asian and Pacific Islanders. So why is this happening, right? What are we doing? Okay, and I will tell you that these disparities or these differences are not ones that are based on genetics necessarily or kind of biologic constructs. So when we look at the data from the UC Health, right, our own cancer center, okay, what you see in this first column right here is our state population, looking at these percentages, and then the percentages of state cancer-wide cases overall, followed by the population that we serve in the cancer center. Okay, and what do we see right here? We see that there's a big difference in the percent of non-Hispanic white individuals in the state compared to the percent of state cancer cases. Okay. And we also see that there's a difference here in the percent of Hispanic individuals that are all races and the cancer rates. And I can tell you what is in the report that might explain potentially this. But then we also notice that there's a drop off here between the number of cancer cases or the percent cancer cases and that which we see in our population. Okay. So I'm curious. I don't have the answers. I have a snapshot of what this data looks like. I don't have the deep dive. But are the rates higher in white individuals because there's something biologically different that is causing these rates to go up? Or is it because they have better access to screening and hence diagnosis of cancer? And I don't have the answer to it. It's just a curiosity that comes to my mind. Okay, when we think about the Hispanic population and the rates here, one explanation that was in the report that I received is that in general in Colorado, this population is much younger compared to the general population of average of 26 years old versus 40 years old. So could that be the explainer for potentially that difference? But then we also have to think about what is the difference between those that are in the state versus those that are being treated in our cancer center. And if further down the line, those are that are actually enrolling in clinical trials as part of the cancer center, right? The research arm is important for our programming. So what are causes of that? And when we think about differences, okay, this was actually a graphic that was created in 2001 to help us understand differences in outcomes and quality of care for minoritized versus non-minoritized populations. Okay, and most of the time we're thinking along social groups. Okay, this can be race, by ethnicity, this could be by sexual orientation or gender identity. Okay, it depends on which demographic we're interested in studying at that particular time. And what we can see here is that not all differences are necessarily bad, right? There is some that is clinically appropriate and related to the unique healthcare preferences, the needs of that individual and their family. Okay. The challenge is there's this bigger part down here on the bottom too, right, that are due to differences in how our healthcare systems work, how our societal structures operate, and discriminate and bias, okay, against minoritized groups compared to the majority groups. Okay. They were previously called disparities or significant difference, as is defined in a dictionary. But because we now recognize that these significant differences are due to structural factors that we have the power to address, because these are the social structures we create. Hence, these are also the social structures that we can deconstruct and reconstruct in a way that is more inclusive of our minoritized populations, right? So now we're using the term inequities because we can address these. We know we can fix them, but how, right? That's the question, right? And so when we think about what health equity is, it's really when every person has the opportunity to attain their full health potential, okay? And no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstances, okay? And I will point out that this is language from the CDC, okay? And I will point out, again, in my work with LGBT populations, even using the binary pronouns here of his or her can be potentially a structural barrier to individuals who may identify as gender diverse or gender incongruent, okay? Which, so you probably noticed I changed the wording to there to try to be more inclusive, just as one example, okay? And when we think about trying to address these inequities, we have to really talk about the difference between equality and equity. So in this graphic, the metaphor for success in life or being able to achieve health equity, right, is for people to be able to participate in this game. Here it's depicted as a baseball game that happens to be at Coors Field. What you'll notice in this picture is that each individual is the same height, okay? They have that same potential, okay, if you want to think of it that way. They have the same potential because they're the same height. But they are not standing on even ground. The individual in the yellow color, right, is standing on a lower ground and their fence is higher. And this represents the different barriers that certain minoritized populations are facing structurally, okay, in the United States, that leads to higher challenges or greater challenges in terms of achieving their goal. And when we think about equality, we're really trying to imagine giving each person a box of the same size to be able to stand on. Okay, so now they all have the same size box. So the person, the blue individual, right, is able to see over this fence. The red individual maybe can peek over if they're standing on their tippy toes. Okay, but the person who is in yellow still cannot access the game. Okay, and so then we want to think about equity. And equity is really recognizing these historical injustices and the different strengths and needs that each individual has and trying to meet them where they're at, right? And so the individual in blue still just needs one box because they can see and they can participate in the game. But the individual in red maybe just needs 2 boxes so they can fully participate. And the individual in yellow needs 3 boxes. Okay. The challenge is that this picture doesn't include individuals who might need a wheelchair for mobility, right? So in this scenario, no number of boxes is going to be helpful for this individual who uses a wheelchair, right? Because they need a ramp. Okay. And so we also want to make sure we're really intentional when we think about equity, that we are including multiple dimensions of diversity, as well as specifically, what is it like we need to do that sleuthing to understand what is it that individuals might be needing. Okay. And as I've alluded to, equity really is a structural issue. Okay. When we think about diversity, equity, and inclusion, we almost always focus at the individual level. I can tell you my training as a physician was almost all at that individual level and at interpersonal level with the patient. Okay. And if something bad happens, we say, oh, this is one quote unquote bad apple. Okay. But we would be really doing a disservice, okay, to us ourselves if we fail to recognize that there are also a multitude of structural causes. So using the apple example below, how many apples grow and what kind really depends on the number of seeds that are planted, the soils that the trees are growing, the air quality, and the amount of sunshine, right? That's our climate. Those are all of the different factors that go into creating, right, an equitable biosphere or not, okay? And so we have to recognize factors such as like how we recruit individuals, how we hire people, okay? How do we provide high quality soil for our patients or our colleagues to live in? Is it an environment that is inclusive and where belonging is really a factor for our individuals that we're working with, okay? Right? These structural inequities, right? These are those macro level systems, social forces, institutions, and ideologies and processes that interact with one another to generate and reinforce inequities. And what I can say is we need to do work at the individual level, but if we don't do work at the structural level, these processes will continue because systems work the way that they're built, right? They work in the way that they're designed. And when they're designed in a way that structurally oppresses some over others, right, we're never going to fix that system just working at that one individual level. So how do we do this? How do we deconstruct this, right? Because thinking about equity and cancer equity, right, can feel really overwhelming, I think, for a lot of individuals. And our goal really is to try to give you a model to break this down into smaller pieces and steps that feel more approachable to you and achievable. Okay. And I will say that if you dig into the literature around this, you'll hear often the term structural racism. Okay. That's the system in which public policies, institutional practices, cultural representations, and other norms work to perpetuate racial group inequality and inequity. Okay, this is the default system that we work in. I will sometimes use the term structural oppression interchangeably with structural racism, because again, like I said, there are multiple different identities that every single one of us holds. And we may hold privilege in one component of our identity, and we might be minoritized or marginalized in a different component. And using the word structural oppression is a way to try to be a little bit more inclusive when wrapping around and recognizing that all of these factors are at play. Okay. So what we do is we use the socioecologic model. Okay, it's a way of kind of teasing apart all of the little structures that perpetuate oppression, and then figure out ways to use those that knowledge to change our systems to be a little bit more inclusive. Okay. And so what this does is it organizes our world, right? The way that we live in sociology is that we all exist at the individual level. And then there's all of these layers of interpersonal, community, and then the structure and society that we live in. And what we'll do over the next few slides is kind of deconstruct this a little bit piece by piece. Okay. And feel free to interrupt me if you have any questions along the way. Christy is going to help me monitor the chat. So if you have questions, please feel free to interrupt. Okay. So when we think about what this looks like at the individual and interpersonal level, okay, we start here because this tends to be where we have a tendency to focus. A lot of our training, both in medicine as well as nursing, is on these levels, right? So really the individual level is a focus on you as a human being. Who are you? What are your core belief systems? Who are you as a person? What are your values that you bring to this? Okay. What are the biases you also carry around this? And thinking about working on that level of trying to understand where you sit so you can change or alter, features like the language that you're using or the behavior, or learning more about what your implicit biases might be. Okay. The next part is interpersonal, right? How do you bring your authentic self into your interpersonal interactions with other people? Okay. Do those interactions allow others to also be their authentic selves? And how do those behaviors influence others and vice versa? Right? So it could be something as simple as, how I approach somebody walking down the street, right? If I look aggressive, I don't know that I'm capable of that, but if I, walk down the street and I always had this mean looking, aggressive face, how that other individual is going to react to me might be slightly more cautious, may even be potentially hostile, because that might be the vibe that I'm emoting at that time. And then I'm going to perceive that other individual as potentially hostile, right? And that automatically creates a potential negative interaction compared to if I were to walk up with a smile, right? They might be more likely to smile and we might be like, oh, that person's a nice person. Okay. And when we think about this, one of these cross-cutting domains, which is this white part over here, is to think about, all of these cross-cutting domains influence every single one of these levels. Okay, right? How much information we have, what is our knowledge base, right? What kind of training do we have? What is our motivation, our attitudes and beliefs in terms of thinking about the world, whether we tend to be like optimists or not, okay? As well as cultural norms and a sense of self-efficacy, okay? And so when we think about this, we really want to make sure, are we sharing information in a way that's accessible to the other individual based on their learning needs? Okay. How do we motivate ourselves to keep moving on? Right. And the last one, of course, we'll dive a little bit deeper into, are what are the norms that are our cultural norms institutionally, as well as what are those biases that we have? Okay. So when we think about bias, we really have to talk about individual level biases here, okay? And thinking about what is the difference between explicit and implicit bias, okay? And as a reminder, the definition of bias is a prejudice in favor of or against one thing, a group, or a person compared with another. Okay, explicit biases are those thoughts, beliefs, and values that we're aware of, right? We can ask people for their explicit biases using direct measures such as surveys that tap conscious processes, right? For example, the General Social Survey for decades been asking, do you think women should work outside the home? Or would you be opposed to having a close relative, marry somebody of a different race? Okay. If you look at the answers to those surveys, you would say that prejudice is declining, and we've made a lot of progress since the 1960s. Okay. Those are explicit. We're aware of them. We can tap into them. We can speak them. Okay. Our implicit biases are thought patterns that we are not aware of. And they look at responses to unconscious processes. Okay. And those can be measured either through things like implicit association tests, but they can also be other measures like how far you sit away from somebody or stand away from somebody, how much eye contact you make is how some of our sociology and the anthropology colleagues measure some of this work. Okay. And when you look at that research, you can conclude that prejudice is still prevalent, even among those who renounce it at the conscious level. Okay. And what underlies both explicit and implicit bias is stereotype, right? Stereotype is that widely held belief, and it's a little like fixed and oversimplified image or idea of a particular type of person or thing, right? So it's that association between, for example, Coloradans and ski, okay? And it comes from all of the information that we take in on a daily basis, whether it's on media, our social news feeds, or from our sphere of influence with the colleagues, the people that we hang out with on a regular basis. Okay. And we don't have time to really do a full deep dive in implicit bias. That in and of itself is an hour-long conversation that we can have at a different time. But what we know about implicit bias is that it's common. Okay, and it stems from our tendency to form associations to help organize our social worlds. And it's learned. They're based on our local norms and structures. Okay, and what we have to realize is that stereotypes exist all over the world, but the content of those stereotypes might be different based on different cultures and geographies. Okay, we also know that they're pervasive and they occur in everybody, regardless of their identity. They're unconscious, okay, and they can often conflict with our explicit beliefs. And most importantly is that they're consequential. Those implicit biases sometimes actually predict behavior better than our explicit views, and they can limit opportunities for the targets of bias, right? Kind of put more simply, right? Sometimes implicit bias is that iceberg that can sink our conscious beliefs and intentions. Okay, they underlie many of our decisions at all of these levels about the socioecologic model when we think about what might be a policy or a way of being might inadvertently marginalize minoritized populations. Okay. So one way that this can manifest is in this concept of microaggressions. And I imagine many of you have probably heard of this already. But it was described in the 1970s by Dr. Chester Pierce. Okay. And what they are kind of everyday slights, indignities, or put downs and insults that members of marginalized groups experience in their day-to-day interactions with individuals that are often unaware that they've engaged in in an offensive or demeaning way. Okay. So this can be things like, asking somebody who appears to be from a minoritized background and whether they need a translator, or are you on Medicaid, when you're not necessarily asking that of non-minoritized patients. Okay. It can even be something of like less quote unquote cheerful banter. As you're bringing a patient in, if somebody looks more similar to you, we have a tendency to be chattier with them and be like, oh yeah, we did this, and right. And then the next person who might be from a different background, are you actually chattering a little bit less? Okay. Or clinically, have we ever dismissed or diminished a patient's concern or report of pain because we are not fully acknowledging kind of their lived experience. Okay. And I'd like to open it up, please put in the chat, what behaviors have you seen? I would love to hear real life examples so we can talk about kind of what the impacts might be. Nothing? Okay. All right. I can assure you that many of our patients have seen this. I personally, I will relate, have been grocery shopping and have been asked where I am from. I am born, raised in the US. I think I have probably been to China 0 times, so much fewer than many other individuals that might potentially even be in this audience. And yet this is something that occurs to me on a fairly regular basis. Even small things like, wow, you are so well spoken, which has good intentions, but implies that, oh, you think I shouldn't be well spoken? Okay. And I think, we've all experienced kind of the occasional rude remark. For many of us, this can be an isolated incident here and there, and you can kind of brush it off, right? But for many of our minoritized friends, family members, or patients, right? These happen on a regular basis, okay? And they can really be important because of the cumulative impact that they have, right? And so instead of like the occasional drop that you can kind of ignore, for some people, it's like a torrential downpour, okay? Right? It can have an impact, like there is data that shows that this has an impact on our performance. It increases our self-doubt. It decreases our engagement with the system, okay? In our colleagues, it can lead to things like imposter syndrome. And in our patients, it can lead to a sense of decreased self-efficacy or fear or distrust of the healthcare system. I know in our work around LGBT health, we hear this as a very common story from our patients of like, I am terrified to come in because I don't know what's going to happen to me. I don't know if they're going to call me by what they call my dead name, which is my legal name, but it's not a name that I use, or if I'm going to be misgendered because people are going to use the wrong pronoun. Okay. For some of our patients, this is actually life-threatening. Okay. We've had patients in our integrated transgender program who've committed or attempted suicide. We've had a couple who we've known have committed suicide related to this on a regular basis. Okay. It has a true impact. When we think about the community level, okay, this can include the actual community that surrounds our Anschutz Medical Campus, but it can also include the community that's within our campus and the clinical structures that we're working in. Okay, so when we think about this, like what kind of outreach are we actually doing into the community to help build trust and leverage the assets of the community? Okay. Are we doing any kind of community education or screening efforts, especially partnering potentially with organizations that work with our minoritized populations that we might be trying to include in both our cancer center clinical work and or our research outreach, right? And are they done in a way that's culturally humble and meets the needs of the community as identified by the community, rather than us, quote unquote, swooping in, as that ivory tower and saying, we think you need this, right? Is it done in partnership? Okay. And I think a lot of things we hear from our community partners is, how, if we enroll in your research programs, how are we and our community going to benefit from the participation? There is, again, because of this historical mistrust, there's a concern that their data will be taken, but to benefit potentially the majority population. And we need to make sure it's explicit how this is going to help that community. How are we going to reinvest into that community? Okay. And then when we think about like the structural level, how do the structures we work in bring and support individuals from marginalized populations? Okay, so for example, if we're primarily recruiting our research participants from the pool of patients that we serve in clinic, what barriers might there be to accessing the clinical space? Okay. What are our clinic hours? Are they inclusive of individuals who may be working 1 or 2 jobs or working families? Do we provide any sort of childcare? Okay. What are the insurance requirements that the system has that prevent people from being seen, right? Or do we have late show policies that might be potentially impacting individuals who have to use public transportation, right? Maybe they're taking 2 buses in order to get to our clinic. And if the bus is running behind, are we penalizing them because of that? Or are we recognizing that that might be an issue and saying, hey, let's let them come in a little bit late? And how do we accommodate that? When we look at the built environment, okay, are people seeing themselves in the brochures or the pictures that are posted on the wall, the magazines that we have in the waiting rooms? Are our intake forms inclusive that allow people to check all of the boxes that apply to them? Okay, because if they can't see themselves in the paperwork, especially from a lot of minoritized populations, they're automatically going to be a little bit hesitant and say, is this place really going to be inclusive of me if I don't even see myself in the paperwork? Okay. Are the restrooms inclusive and welcoming for individuals of all gender identities? Okay, the vast majority, especially if you practice at UC Health, the vast majority of the restrooms are on the gender binary, right? There's men's restrooms and women's restrooms, and there's a handful of single stall kind of restrooms that are not necessarily gender identified, but they're not quite as visible, okay? And what resources do our patients have access to? What do we offer them? Like, are there resources that they need to feel welcomed and engaged in their care? Do we, when we're recommending resources, are we aware of the different community organizations or support groups that might help with their particular affinity group, right? Whether it's, for Hispanic or Latino individuals, or whether it's for LGBT individuals, what kind of support groups are they set up for? Okay. And do they see people who look like them in the environment? Are they seeing providers or staff that look like them so they can feel more welcome and more included? Okay. And then are resources offered in multiple languages? Okay. And then thinking about organization systems, right? This is how we organize the work that we do on a regular basis. So where are our clinic locations? Are we expecting everybody here to travel to the Anschutz Medical Campus, or do we ever offer outreach opportunities, potentially in more minoritized or socioeconomically disadvantaged or marginalized areas? Okay. Excuse me. How do our databases capture the patients that we're actually seeing? So I am not a researcher, in full disclosure, but I did go, try to do my research. So I went to the SEER database, which is the one I'm aware of. Okay. I'm wondering if anybody can tell me, this is a screen clip of how you can get started in terms of exploring the SEER database. Okay. And what I did was I just took a screenshot of what I saw. Are there any challenges that you can see based on this screenshot of the SEER database?
We have limited gender choices. Thank you.
Thank you, Jill. Right. Yeah. So this one identifies along the gender binary. Okay. So it doesn't necessarily allow for individuals who might identify as gender incongruent or gender diverse to identify who they are. Okay. We also don't have the opportunity to identify based on sexual orientation. Okay. And then, I think race ethnicity is also a challenge here. There's a lot of lumping, and I can tell you that we
Rita, I'm not sure, you're muted, and then we had some feedback.
Is that any better?
That is perfect. Thank you.
Okay, my computer has this knack of cutting out when it's most important. Sorry. So where did we leave off?
I think we're kind of at what are the barriers, what could be done better, some of the missing data that's not on here.
Okay, thank you. Yeah, so, when we think about all of the racial identification, is it inclusive of the different groups that people identify as? I know I can speak for a lot of my Asian colleagues that, Asian individuals are not one monolithic culture. There are, minoritized groups of individuals within the Asian subpopulations like Hmong, Burmese, and Vietnamese, where they feel like they're getting kind of rolled in and marginalized further by not being counted because they're rolled up into the larger Asian community. And there are different challenges that different subgroups face. And I would say the same thing can happen with individuals who identify as Arab, Middle Eastern, or North African descent to self-identify, right? The US Census actually classifies them as white, but if you look at research data, about 85% of individuals who identify as Arab, Middle Eastern, or North African feel like they are a minority population, and blending them into the white population does not adequately account for their experience. So we've brought up a lot of challenges, or hopefully at least started you thinking about what might the challenges be that we can actually start to address. So now what do we do, right? This feels so overwhelming, or it can feel overwhelming, of where are we going to start? How are we going to solve structural oppression across the United States? And we don't have to, take it all on at once. And so what we like to do is to use the socioecologic model, right? We use it to deconstruct, and we can also use this to select what are those next advocacy steps that we want to do. Okay, where is it that you, leveraging your skill set, your interests, and your sphere of influence, where is it that you want to operate to make something happen? Okay, to make an improvement. Okay, when we think about at the individual level, okay, one thing you can do is just be an upstander, right? An upstander is somebody who speaks up if you see something, right? There's, in patient safety, it's you see something, say something, right? So if you see a microaggression or you accidentally commit a microaggression, do something about it, right? Speak up. You can directly intervene or address the situation in the moment. Like, hey, I don't think what you said was actually really cool, or help me understand what you meant when you said, right? And it's a way of approaching this in a way that kind of calls out that something has happened, but it also calls them in. So you're trying to approach it from like an understanding perspective of, I'm going to assume you didn't mean negative intent or mean harm by this, but did you realize that it could be harmful, right? Or if you commit the microaggression, apologize. I microaggress all the time. I'm getting better at catching myself in the moment. So sometimes I'll say something like mankind and like, oh, I mean humankind, and I can catch myself. And other times I miss it until an hour later and I'm like, oh, I should have said that, right? Or I didn't mean to say that in that conversation. Okay. If you're not in a supervisory role, or you're interacting with somebody who has a lot more power in your hierarchy or your structure, try to redirect the conversation. So we're trying to do less harm, right? It's a harm reduction strategy. Or delegate, invite a colleague or a supervisor over to kind of help address the situation. At the minimum, we really encourage you to use at least body language to be like, that was not okay. Like, did you really just say that? Right? Or even just like stopping mid-sentence and looking like, I'm not going to say something. And then that allows the other individual to recognize that they said something. Okay. At the minimum, if you witness something, we always encourage everybody to debrief, which is the opportunity to reflect and support one another. Okay. And if you're not sure exactly what to say, it could be something like, hey, Christy, I saw this individual said that. I was worried that, that was a microaggression. I'm not sure how you feel about it. I'm wondering if you would like to talk about that. Okay. What else can we do, right? We need to also think about at the community level, what are those things that we can change? Okay. Do we want to start doing community outreach if we're not already doing it? Or if we are doing it, do we want to be more intentional about where we're doing those community outreach? Okay. Or those networking, or do we need to build up our list of resources so when we are referring patients to support groups, that they have an affinity group to go to? Do we know what those are? Okay. So this is where I'm going to begin to have you think about what is your commitment to action. Okay. I need everybody to say at least one thing that they're going to do. Okay. And some of it might depend on what your role is, what your sphere of influence is. If you can control what insurance UC Health takes, go for it. We'd love to see that be a little bit more inclusive, right? If you control the registration process, work on that, or the forms, etc. That's what we really want you to do. And what we want you to do is post that into the chat for all to share. And we also know that if you write it down, you're more likely to carry through. Okay. Before we finish and go to kind of discussion and questions, I hear a lot of people say, I'm afraid to do something because I'm afraid I'm going to do the wrong thing. Okay. I have that fear too. And yes, sometimes we are going to accidentally do the wrong thing. Okay, but this is a quote that my friend and colleague, Teresa Jones, just sent me recently that really rings true to me. And it's from Amanda Gorman, right? I'm a firm believer that often terror is trying to tell us of a force far greater than despair. In this way, I look at fear not as cowardice, but as a call forward, a summons to fight for what we hold dear. And yes, I am still terrified every day, yet fear can be love trying its best in the dark. So do not fear your fear. Own it, free it. The truth is, hope isn't a promise we give, it's a promise we live. And I hope you'll all live your promise. And I will stop share and open it up for questions, discussion. And Amy, thank you for sharing. So stop referring to women as girls. I have mixed feelings about the you guys. I don't generally like it because I don't think I identify as a guy.
That's so true. I say you guys a lot, and I'm not talking to just a bunch of guys. I'm talking to everybody. So it's when you get as old as I am, it's like, oh, I've been saying that all my life. This was very, very thought-provoking and very thorough, Rita.
Thank you. Any questions?
Let's see here. I guess we've already covered the things that were in chat. Does anybody have anything they want to unmute their mic for and talk about? You're welcome to do that.
I tend to use y'all or hi everyone a little bit more.
Y'all.
Encourage people to think about if there's particular challenges that you're facing right now and want to maybe bring up in the group setting. that the group could benefit from. If anybody has anything that they want to kind of say, what do we do with this, or how could we improve that?
Yes. Well, we would encourage you to talk amongst your team members and your teams and groups and clinic groups and wherever you gather. I think there's a lot of food for thought here. And I will tell you that this has been recorded and it'll be available. It usually takes several days to get it edited, and it will be available on the intranet. And I can share that with anybody who wants to contact me at the Cancer Center or just by email. If there isn't anything else, I guess we can close unless you have some closing comments, Dr. Lee.
No, I would just encourage all of you to really, again, think about how this plays out in the work that you do. And since we didn't have time to go around the room and figure out what everybody's job was, we'll trust you to do that and to really, think about where is it that you want to have an impact.
That's a good point. If it's all just coworkers, or if you see patients, or even in your private life, right? All right. I will be sending out attendance certificates to anybody who wants them, and I will just send them to everybody. You can save it if you can use that for any continuing ed like SOCRA or ACRP, something like that. So really appreciate everyone joining in, and thank you again, Rita and Christy.
Great. Thank you so much. Appreciate the invite.
Bye-bye.
Okay. Bye.